Okay, great. It looks like we have a good number of folks here in our webinar. So Mary, if you'd like to take it away.
Wonderful. Thank you, Lissa. Hello, everyone, and welcome. I'm Mary Catanese, and I'm a part of Women in Science. Thank you for joining us from Women in Science for our event today. We're inspired to create this panel out of the dire need for improving inclusion in research and recruitment, as this is a fundamental question we must ask ourselves as scientists and as members of society. For if we don't study everyone, how can we treat everyone? So these are questions of research and medicine, as well as social justice. So we put together this wonderful panel, and we're very honored to bring together an amazing group of panelists who are personally and professionally dedicated to improving inclusion in research, medicine, and clinical care. I'd like to thank my Women in Science colleagues, Lissa Manning, Olivia Schneider, and Natalia Slepneva for helping organize this. And just to let you know that the basic structure of the event, our panelists will first present brief talks, and then we'll move into a panel discussion. And so please use the Q&A for your questions. And as a note, we're going to hold all questions apart from any that might be clarifying during the talks. But then at the end of the brief talks, we'll come together and we'll have a discussion and panel section. And then Lissa will man your questions or woman your questions. So I'll take a moment now to introduce all of our panelists, and then we'll begin. Dr. Arundhati Nagendra, PhD, is a postdoctoral fellow from the Mongan Institute at MTH and works in the Disparities Research Unit and the Center of Excellence in Psychosocial and Systemic Research. Dr. Nagendra studies how various forms of racism contribute to disparities for Black Americans diagnosed with schizophrenia, and her long-term goal is to address the needs of these individuals to promote recovery as well as their empowerment to seek the treatments they need. Dr. James Morrill, MD, PhD, is Medical Director of the MTH Charleston Health Center and Assistant Professor of Medicine at MGH. Dr. Morrill is a physician and scientist dedicated to community healthcare with a focus on treatment and interventions for individuals with addictions specifically, and is committed to improving inclusion and access in healthcare and in educating medical students and upcoming physicians about these areas of need. Juliana Eison, Research Program Coordinator from MGH's Community Access, Recruitment, and Engagement, or CARE, Research Center, is working on questions related to improving inclusion in clinical research and practice and addressing stigma and inequity in relation to mental health. Finally, Dr. Angie Sanchez is a physician scientist with family and community practices and is dedicated to the health, well-being, and advancement of communities. She has experience with vulnerable communities such as rural and low-income populations and has expertise in conducting health promotion and disease prevention programs in hospitals and community health centers. And she worked in underserved neighborhoods in Colombia. She is currently a research fellow of neurology at Harvard Medical School and the assistant director of CARE Research Center, where she is dedicated to investigating the science of community engagement to develop new strategies to improve access to research, healthcare services, and quality of life in vulnerable communities according to their individual needs. And now we'll begin with Dr. Nagendra, who will discuss what is at the heart of health disparities and barriers to inclusion. Take it away, Arun.
Gotta unmute myself. Can you see my screen okay? All good. Great. All right. So hi, everyone. Thanks so much for being here. So in the next 7 minutes, I'm going to attempt to outline the
scope of mental health disparities as they pertain to communities of color, as well as some factors that may underlie these inequities. There is no way I'll do this justice, but my goal is really just to highlight some broad patterns and kind of show the importance of doing work in this area. So I'm going to start with the prevalence and outcomes of mental health problems in communities of color. In epidemiological studies, researchers have observed a particular pattern. Individuals of color or communities of color have comparable or sometimes even lower rates of mental health conditions than their white counterparts. Once diagnosed, the course of their illness tends to be more severe and has longer lasting consequences in terms of disability. So, as an example, Black Americans tend to start smoking later and smoke fewer cigarettes per day than their white counterparts, but they still end up with more tobacco related illnesses and tobacco related mortality than their white counterparts. The one kind of set of illnesses that seem to break this pattern are serious mental illnesses like schizophrenia, with communities of color having both higher rates of diagnoses and worse outcomes. So Black Americans, for example, are 2.5 times more likely to be diagnosed with schizophrenia than white Americans, and Black Americans diagnosed with schizophrenia are at higher risk for homelessness, incarceration, multiple hospitalizations, unemployment, and even suicide. There's much more nuance to this, including that we may actually be underdiagnosing mental health conditions in communities of color or catching them too late. But that's kind of like a broad overview of prevalence and outcomes. Now, why do these disparities emerge? I'm going to highlight just a few different considerations. So we know that one common risk factor for the development of mental health conditions is social exclusion and marginalization. So in that context, it's no surprise that racism impacts the development of mental health problems. As one example, more frequent experiences with police abuse are associated with psychotic experiences in the general population. And unsurprisingly, Black Americans experience more psychotic symptoms than their white counterparts, although this is also partially attributable to assessment bias. Another example, financial stress is associated with the development of mental health conditions. And due to systemic racism and discriminatory policies, many communities of color experience more financial stress. Racism can also enact its effects in more insidious ways. For example, the presence of alcohol and smoking outlets is concentrated in communities of color in the US. And here's an example of how cigarette companies deliberately marketed mentholated cigarettes, which kind of like ease a path into dependence to Black Americans. And this was a very deliberate marketing strategy. Similarly, here's an ad for Thorazine, an antipsychotic prior to the civil rights movement, when schizophrenia was viewed and treated as an illness that was harmless and mostly impacted white women and intellectuals. You can see they highlight here the treatment of emotional stress. Here's an ad for antipsychotics in 1968 after aggression was added to the criteria for diagnosing paranoid schizophrenia, and after the scientific establishment began to describe acts of civil disobedience as pathological. So all of this to say, racism can impact the development, conceptualization, and treatment of mental health conditions. There's also a clear role that culture plays in mental health. Our paradigms for understanding and treating mental illness are largely westernized. As a possible result of this, studies show that the more communities of color or individuals of color assimilate into the majority white culture, the more likely they are to engage in mental health care. Unfortunately, assimilation is also associated with more mental health problems, such as higher rates of substance abuse. Interestingly, second and third generation immigrants are more likely to develop serious mental illnesses than first generation immigrants, pointing to the importance of culture as a contributor to these disparities. I say all of this to start to give you an idea of the complexity of these issues and the resultant need for research in this area. Unfortunately, an assessment of 30 years of papers in prestigious journals from the 1970s to the 2010s estimated that only 5% of psychological publications reported on race. In developmental psychology, it was 8%, in cognitive psychology, 1%. When it comes to thinking about the role of racism, not just race and ethnicity, another paper evaluated 30 years of articles from the New England Journal of Medicine and JAMA and found that 15 out of 85,000 papers use the word racism. So rounding up, that's 0.02%. So one consequence of this is that our constructs, our study questions, and our assessment materials remain colorblind or whitewashed. As an example, here is the eyes task, a widely used measure of social cognition that's supposed to infer your ability to tell like the mental state of other people. So you can see, for example, this person may look suspicious, this person looks a little bit panicked. This entire task consists of white faces, despite research showing that people are much better at identifying emotions in people who share their racial or ethnic background than those who are outside of that. Somewhat unsurprisingly, communities of color have lower scores on the eyes task than their white counterparts. And many assessments used in psychological and psychiatric research have not been cross-culturally validated. It's a daunting task, but without doing this, the very foundation of our research and consequently our treatment is flawed. Lastly, studies also suggest that when scholars do report on communities of color, they just include race or ethnicity in sample descriptions, or they statistically adjust for it rather than treating these as valuable constructs in their own right. To be clear, I'm not saying that every single psychological construct is related to race or racism and culture and anything like that, but I'm just trying to highlight that racialized experiences such as culture, inequality, and segregation shape cognition, development, mental health, and behavior. Downstream, and this is I think going to be the focus of this, the lack of this panel, the lack of attention to race, ethnicity, culture, and racism is that our treatments for mental health conditions or even our systems of care are lacking in terms of being culturally tailored. The mental health system often fails to engage individuals of color in treatment to the same extent that they do white Americans. And jarringly, Black Americans are more likely to be involuntarily hospitalized, so involuntarily forced into treatment than their white counterparts. One study even showed that physicians are 23% more likely to be verbally dominant, like more likely to talk than to listen, and 33% less likely to engage in patient-centered communication with Black Americans than white American patients. I'm going to wrap up, but I just want to point out that a huge problem here is the lack of representation in researchers, in clinicians, and in research samples. 5% of US MDs are Black, and the same percent, and it's about the same for the percentage of psychology professors. And there's a lot of variation, but in general, there's a lack of representation of communities of color in psychological research samples. This is especially important to remedy, especially given estimates that in the next 2 to 3 decades, it's estimated that individuals of color will outnumber white individuals in the US. But I'm hopeful that, you know, these patterns are starting to change, that more attention is being paid to this area, and I'm really excited to be a part of the panel for that reason. So I'll wrap up here and hand it back over to you, Mary.
Thank you so much, Aaron, for that excellent and very important discussion about erasure in research and assessments. Thank you. We'll next hear from Dr. Jim Morrow about his work at the Charlestown Healthcare Center and about structures in place and ways to improve community-based health in relation to barriers of exclusion within the community.
Thank you. It's a pleasure to be part of this panel. And I don't have any slides, but I'm going to try to just make kind of 4 brief points. The first, as someone representing a community health center, to talk very briefly about the community health center model and how it may be kind of an ideal, the sort of community health center ideal, maybe an ideal partner for community-based researchers who are hoping to do inclusive research in communities and engage with communities. Secondly, to talk a little bit about the MGH Health Center system and a little bit about the dilemma of having health centers that are also part of academic medical centers. And there's sort of pros and cons of that and things to think about and watch out for there. And then third, talk about what has felt like a bit of a success story for our health center engaging with researchers and our community in one particular area. And then fourth, talk about some real growth areas for us as a health center, which if we kind of can meet those goals may help us be an even better partner for the research community here in engaging with communities. So first, the community health center model. So I think many people know this, but community health centers, the modern community health center movement was born in the mid 1960s as sort of as part of the war on poverty. And I think many people know the story of 2 visionary physicians from Tufts University, Jack Geiger and Count Gibson, who were the ones who sort of thought that you could come up with a good model of taking war on poverty money and devoting it to healthcare. And then that was a key way to meet some of the goals of the war on poverty and actually social justice as well through healthcare. And their initial health centers through this model, one was in Dorchester, Massachusetts in 1965, and then a few months later in the Delta of Mississippi, Tufts Delta Health Center, kind of were trying to live up to this ideal. And the way the model was constructed is it had built into it, federal support. So these health centers had federal funding, but what was required is that they had a community board that governed the health center. It wasn't just an advisory board, it was a governing board. And 50% or more of that board had to be consumers who were getting their health care at the health center. And that actually was the way the model was set forth in the 60s. It kind of spread like wildfire across Boston. Actually, there's a great story about the Boston Community Health Center model and across the country. And that's the way the federally qualified health center model, as it's called, is set up. And so it's kind of integrally, interdigitated with its community in that the community governs the health center. The model is to bring the health center into the specific community, has to be part of it. The community has to be part of the health center, and the community governs the health center. And so in that sense, you could view it as sort of the ideal bridge between researchers wanting to meet communities where they are and really win the trust of those communities. I think that trust is supposed to be built into the model by the way it's constructed. So that's the ideal model. And I'll say a few words then in my second point about the MGH health centers, which are a slightly different model. So they arose, Mass General Charlestown, which is where I work, was the first of the MGH health centers to be born. It came online in 1968, so just a few years after the community health center model was born as a whole. It came out of many of the same forces. So it was a collaboration between community groups in the neighborhood of Charlestown, one of which was the Kennedy Center. That was a key one. That was getting war on poverty money to fight poverty through programs for families and children. That was one of its main foci. Recognized the need for increased health care for families and children in the neighborhood, which at the time was a really underserved neighborhood. It was one of a number of neighborhoods in Boston that were literally in the shadows of these great academic medical centers, but had very, very poor access to care. So that was one piece. The city of Boston was another piece. They had this network of buildings throughout the city, which were built back in the 1920s under the George Robert White Fund as kind of health and hygiene centers. They weren't modern integrated community health centers. They were collections of kind of public health functions in one place. But they recognized that some of these buildings were ideally located to provide healthcare within these communities specifically. And then in this case, and this happened in several other cases across the city, but MGH really stepped up, brought these groups together, thought about how they could stand up healthcare in the community, and then said, we are actually going to be the ones who stand up this health center. We're going to provide the healthcare. We're going to staff it with the doctors and the nurses and the other staff. We're going to provide the infrastructure. And we are actually going to be the ones who own this health center. And so the building came from the city. The inspiration came from the community groups. There was some funding from the federal government, but the core infrastructure and founding of the health center came from the academic medical center. And that same model was reproduced a few years later in the city of Chelsea with a very similar kind of set of ingredients that gave rise to an MGH licensed health center in Chelsea. And then within a few years of that in Revere. And it's interesting, like our health center in Charlestown has stayed in the same 90-year-old building, which has been modernized internally several times, had some renovations. And in Chelsea and Revere, the health center has kind of moved into different locations over the years, but the same model has persisted. So the question is, what is different about that model than between that model and the federally qualified health center model as originally set forth in the spirit of Geiger and Gibson in 1965. And the answer is that community responsiveness is not necessarily automatically baked into the model. It is not a requirement. We are supported and fostered and kind of cradled by the academic medical center. And they've been very generous with their support and very supportive of kind of essentially everything that we've wanted to do. But we do not have to have a community board in order to exist. And that is, in many ways, I think, a danger. I think there's a danger that these academic medical center owned community health centers in this model, as much as we sort of came out of the same ingredients, we can drift away from that community health center spirit. And that's something that we have to very much be conscious of. And I think there are pros and cons. I mean, I think that if we can be as honest as possible to that spirit, we can play that role of the sort of the ideal partner for researchers. We're very closely connected to the academic medical center. And in fact, many of our physicians play academic roles at the hospital and also work in the health center, or administrative roles at the hospital and the health center. And so it's very easy to get connected to research projects. But where we drift is in our relationship potentially to the community. And I think we really have to watch out for that. So there are pros and cons of that model. So that was my second point, is to sort of locate the MGH health centers or academic medical center owned health centers in the space of health centers, and how they may differ, and how there's a danger that they may differ from the original conception of community health centers. My third point is that, at MTH Charlestown, I mean, I think we have a good example of it working well. One of the things that has confronted us as a health center over the past 15 years is the opioid epidemic. And I think many people on this call are well acquainted with, its ravages across the country. And there are many dimensions and many different populations and parts of the country. But in Charlestown, we were seeing populations of young people using pain relievers, transitioning to heroin, transitioning to injection drug use, getting hepatitis C, to a much lesser extent HIV, and multiple overdoses with early and later waves of those over time. And so our health center physicians recognize this for a complex set of reasons. Charlestown was really an epicenter of this, and our patient population was hit hard by this. And so we were early adopters of Suboxone therapy, recovery coaching, addiction nursing, and did a lot to try to engage with that specific slice of our patient population. And because of that engagement, when research came along about the treatment of hepatitis C, and there were important innovations in hepatitis C treatment, and we became very interested in primary care-based hepatitis C treatment, because it was very clear that there were bottlenecks to getting, particularly patients affected by substance use disorders, into specialty care for hepatitis C. We were a willing and ready partner, and the bright spot that we experienced in collaborating with researchers was something called the HERO trial, which was a trial not of whether antiviral treatment was effective, because that had already been proven. These were with the new, highly active antivirals, that are oral and have very few side effects and are very, very effective for eradicating hepatitis C. But the question was, can they be deployed in a substance use disorder population that is either actively using or has very recently been actively using? And so we basically took our infrastructure, including addiction nursing and recovery coaching, added some community health workers, which is something that we were wanting to build as a community health center, engaged with the research team, and had a program of directly observed therapy, some of which was on site at our health center as patients were coming in for addiction care, and some of which was actually out in the community using an app on their phone to kind of directly observe the administration of the pill. And these were regimens that were getting easier and easier. They were essentially just one pill per day for 12 weeks. And in the end, we were one of many sites, but we were able to, through all the bumps, and twists and turns of this study, to show, along with the other sites, that in fact it was essentially equally effective to treat current and recently active substance users with these antiviral therapies with just as good efficacy as were seen in the original registry trials. And this is a really important population to target because it tends to have a high community viral load, high prevalence of hepatitis C, and it's an actively using population in many cases, or cycling back in and out of using, that will transmit the virus readily. So there was a lot of reason to engage with this specific population, even though, you know, the original research studies totally shied away from this population because it was not seen as an easy population to engage with. And the only way it could really happen was through a community health center that had deeply engaged with this population. So I think this was an example from our health center where it worked. And my fourth and final point, and I'll finish up with this, is just that I think at Charlestown, we really have grappled with our growth area of drift from the community health center ideal a little bit. And where I see that the most is that, you know, I'm not sure we understand our current geographic population very well. And that's because, in part because we haven't had to have a community board. MGH has done a wonderful job as a hospital of engaging with communities. And one of the things that and essentially what these have done is been an institution-wide workaround for the fact that we don't have true federally qualified community health centers. In other words, they have done things like put community coalitions into the communities of Charlestown, Chelsea, and Revere that have real independence from the hospital and are separate from the community health centers. And those have really helped us to engage. But I think we have drifted away from an understanding of our community, and our community has really changed. It's a very complicated place with multiple layers now. The original underserved population was primarily, you know, working class white residents who'd been there for generations. And what we have now is, you know, on the one hand, tremendous gentrification within the neighborhood, which has really changed the demographics of sort of half of the neighborhood. And we have a large public housing project, which has also been there since the 1940s. But in the 80s, it was fully integrated across the city of Boston because it's part of the Boston Housing Authority. And so that is now home to many people of color, many immigrant groups and populations that were sort of not part of the original genesis of the health center. And I worry that they don't have enough of a voice in what we're doing. And therefore, you know, if a research team comes in to partner with us around inclusive research and engaging with the community, they may not at this point be as well represented as they should be. So the steps that we're taking are to engage with the community coalition in Charlestown, the Charlestown Coalition, that was set up by MGH, but is now quite independent, engage with other community groups. We're starting a patient and family advisory council, which I would like to see morph into more of a true advisory board with as much power as possible. I think the patient and family advisory council model tends to be a little tepid at times. And it's a very important model, but I would like to see that be a sort of a group that can really move us. And we're engaging with other community health centers across town. North End Waterfront Health, which is a federally qualified health center based in the North End, has a few physicians in a satellite practice in Charlestown, and we've done joint projects with them in the Bunker Hill development, including a drop-in resource center called Crossroads Resource Center. And then finally, we are wanting to work as much as possible with the Center for Community Health Improvement at MGH, who has done, in collaboration with other health systems around Boston, large and small community health needs assessments. And we really want to kind of re-engage with that process and focus some of that on our neighborhood so we can really get to know the community better and jump as a health center more energetically into that. So these are the ways that we want to try to reconnect with the original idea, getting back to my first point, as set forth, of the true community health center spirit. So those were my 4 points. Thank you very much for giving me the time and for allowing me to be here on this panel.
Thank you very much, Jim. Thank you for your historic and structural view and insights. Thank you. Julia Eison is next and will discuss her role in the CARE Research Center. She'll talk a bit about the mission and goals of CARE, as well as her research around interventions to improve inclusion of individuals from historically underrepresented groups in relation to recruitment. So following upon Jim perfectly.
Thank you so much, Mary, and thank you everyone for having me here today. I'm going to go ahead and share my screen. So, I work at the CARE Research Center, as Mary said, which stands for Community Access, Recruitment, and Engagement. And our overall mission is to increase the diversity of those who participate in research. So this is important because increasing diversity and representation in clinical trials is not just something that we do to meet certain participant demographic quotas. What it actually means is that our research becomes more representative and thus more generalizable. In fact, we see that 1 in 5 FDA approvals differ in exposure and response as a function of racial and ethnic group. So, in short, the thoughtful inclusion of diverse groups in clinical research simply makes for better science. So what do we do at CARE? We do 3 main things. The first thing is consultations. We also do community outreach and events, and I'll talk a little bit about how this is also related to research. And then we also do research. And so that is the main thing that I work on at CARE. And so, as Mary mentioned, I'm a research coordinator. And so to me, research coordinating is essentially research and relationships. And so in general, for research, which involves human participants, research coordinators are effectively your boots on the ground. And this is a concept that we will revisit in a minute. So here's some general advice for increasing diversity and inclusion in research. So the first point I have here is building in multi-layered benefits. And so the first here we have is equitable and expedient direct payment for participants. Also, newsletters so that participants can stay engaged and understand what's happening with the trial. Return of results to the community. It's really important that after the study is done, participants don't just have no idea what happened, but they actually understand what happened. They understand how their role played a part in that. And then referrals to other research in or around the clinic. So this can be whether or not someone is eligible for research for the particular research study that you have going on, but also can just help them dip their toes in research happening around the center and the clinic. At the end of the day, this idea of multi-layered benefits is vital because research is a bidirectional relationship and both parties must benefit. So speaking of relationships, we go on to this next point. So building relationships with the community is crucial. As we found in one of our recent studies, the Alzheimer's Disease Neuroimaging Initiative study, we discovered multiple paths to effectively approaching diverse and inclusive research engagement, recruitment, and enrollment. However, community engagement and partnerships, in whatever way that looked like for the site based on their own strengths as a site and an organization, turned out to be a very salient ingredient for recruiting diversely. So community engagement can be in the form of ongoing general educational seminars about the disease area and research. This could be on local media stations, such as radio stations, TV stations, even the local newspaper, for example. And then it could also look like research coordinators attending local support groups, research teams partnering and or sponsoring local community organizations, and things like that. But there are many different ways to effectively engage and build relationships with the community. In terms of building relationships with local community health centers and local providers, this point is also crucial because if you're recruiting, for example, at a community health center, you don't just want to add it as a recruitment site. and then just hope that providers will, you know, talk to their patients about your study. Typically, the providers at these different organizations are overburdened with lots of different work. And so it's important to provide benefits and build relationships with these individuals and community health centers as well. And additionally, as always, it's important to mention that we're also building relationships with research participants. And so, in fact, one of the greatest ways to minimize attrition in research is if a research participant knows someone from the study team by name. That is, they have a relationship with them. And so, all of these different things are really important for increasing diversity and inclusion in research, and actually building relationships is one of the things that I value most as a research coordinator. And so this also relates to building participant engagement and recruitment into your budget. It is vital to ensure that your study has the resources that it needs to actualize these recruitment goals. As we can see, many of these different points, from newsletters to building relationships, are all related to some member of your study team getting involved in these. And typically, it might be a research coordinator. And so if someone is a sole research coordinator on a study, they're likely to be managing all the many moving components that go into building out the study and building relationships with the community and participants. So ensuring you have adequate resources and efforts allocated for all these different activities is really non-negotiable. And so, as you can see, I kind of got a kick out of using the word build to start these first 3 bullet points, but that's really honestly what it's all about. You can't implement any one of these ideas without building it into or weaving it into the fabric of your study. And so now I'm going to go ahead and pass the mic over to my colleague, Dr. Angie Sanchez, in just a minute to talk more about barriers to research. But I do just want to recommend that if you're ever puzzled by low recruitment in your own study and or are looking for more recommendations tailored to recruitment, I encourage you to talk with your whole research team, including your research coordinators and or research assistants, who, as we mentioned before, are your boots on the ground and may have some helpful insights that they could have witnessed in their day-to-day experience. So thank you so much for having me, and I'm grateful to be on this panel with you all today.
Thank you so much, Juliana. This is wonderfully helpful information. Next, we have Dr. Angie Sanchez, who will further discuss perceptions and barriers to inclusion, and who will offer additional specific ways that researchers can improve recruitment efforts, and how we as researchers can better understand what we might be able to do to give back to communities. So thank you.
Thank you so much, Mary, and this is a wonderful invitation. I'm so happy to be here. So I do have some slides that I'm just going to try to go very quick because we are like running, our time is almost over. But this is going to help us to basically summarize what people have been like saying during this panel. And then just note that these slides are usually the ones that we use at CARE, not only me, but also Juliana and our director, Jonathan Jackson, to basically explain people why we are doing bad things in terms of trying to recruit diverse population in our studies. So we usually would like to start this conversation quoting Martin Luther King, that basically in 1965, he says, of all forms of inequality, injustice in healthcare is the most shocking and inhuman. And probably he was referring to all the injustice that was related to health and race, especially the Tuskegee study. So those that are not familiar, this was a syphilis study that was actually, it lasted for around 40 years, that there were a lot of medical abuses. They infected Black communities, and they just like leave it untreated, even though when penicillin was discovered years later. But in addition to that, you may wondering what other medical abuses, and I'm going to speak a little bit about all regulations that came after this Tuskegee study. But what it is important is just to highlight that medical abuses have been in the history of the US or in the history of the whole world for so many years. And this is not only happening in the Black community, such all the abuses that I'm like listing here and you can see in your screen, but also you can also see that there are medical abuses in other populations. We have forced sterilization in Puerto Rico. We have also medical abuses in the ICE detention centers. There are also in history in the World War II, some medical abuses with between Germany and Japan and all the army that were just like basically doing procedures without anesthesia. And then lastly, we also find that there have been different medical abuses related to consent forms, where people are now getting informed and they are just like receiving medications or any kind of treatment without understanding what they are like actually doing. So as I said, there are like different regulations, and this especially the Vermont report came after the Tuskegee study, and are intended to actually protect humans from all those medical abuses. Basically, it relies in three concepts: respect for persons, beneficence, and justice. But after this report, we still can see medical abuses in the United States. And that happened like many years ago, but still we are like not having diversity. There are like mistrust, especially for those medical abuses. And you can see that in addition to the Belmont report, there have been another regulations in the United States that actually are trying to actually regulate those medical abuses, trying to reduce or trying to eliminate those medical abuses, and at the same time trying to improve diversity in our studies, trying to encourage researchers to incorporate diverse population in their study. However, not surprising, the data is not good. So what you are like seeing here is like the US population compared, like the blue table has actually the number of or the percentage of minority participants in clinical research, and then it is compared to the US population. So you can see, and you probably will say, okay, let's see Black or African American communities. So it says that 8% is represented in these studies, while 13% is the overall Black population in the US. You can say, okay, we are not doing that bad. But actually, our director, he just liked numbers, and he just started like looking around those numbers. And it happened that this number is much lower when we get the median. And actually, representation in clinical studies for Black population is only 3%. And then if you go to the Hispanic community, Hispanics, we are the fastest growing population and the bigger minority population in the United States. And we are only being represented by 8%. And then you go Asian, and it happens that, okay, it's not, you will see that the number is not that different. However, Asia is so big, the continent, and we have East Asia, South Asia, and culturally they are like completely different. And we just don't know which or who are the people being represented here as the name of Asian. Here, this is just a study that I did where I took the hospital research demographics, and then I compared to the Boston population. So normally we usually say, we don't need to say which color represents diverse population in Boston and which color represents diverse population in Mass General. But again, if you still don't get it, Boston is considered a diverse city. Mostly people living here in Boston are diverse. So that means that the green color is represent diverse population. And then at the hospital, unfortunately, most participants in our research studies are white. And then if you're like wondering what we mean with diverse population, I think that we need to go beyond race and ethnic minorities, because there are other ways to improve diverse representation in our studies, and that we usually don't care about those populations, so we just don't often record that information. So we also have rural population, we have low income, low education population, women are underrepresented in our studies, and the community LGBTQ. Just like as I mentioned, all of these communities can intersect with racial and ethnic groups. And then if you are like wondering why we cannot recruit diverse in our studies, there are like several reasons. And there is not only mistrust, as I was just talking, due to the medical abuses, we also have other reasons. And those probably can be summarized in these 10 points. So you have lack of awareness. People just don't often know what research is. Also, there are like problems about transportation, lack of money, time commitment. Our inclusion and exclusion criteria sometimes is very hard. And even though when people want to participate, the inclusion they just don't qualify for the study. So we probably need to start thinking about that and how we can make more flexible our studies in order to improve this participation. Of course, there are like fear. People just don't want to be placebo. They want to receive the treatment, or all the way around. Health insurance coverage, especially for those who are under insurance or just don't have insurance. And then lack of return of value. Return of value is that we can also call it benefits. Are we actually giving an extra benefit in addition to the actual treatment? Because all those IRB protocols usually say the benefit is that the participant, they're just gonna receive the treatment and they can just like have better control of their disease. But it's actually that a real benefit. They are spending time, they are like actually not going to their work just because they need to do this study. So which other benefits we can provide to them? I'm just gonna skip this one. So let's start like seeing our problem as this like a workflow problem. On the right, you will find all the barriers that I just mentioned, and on the left is usually what our studies needs to have in order to recruit participants in general. So you will see that each step are linked to one barrier. And some of the steps are linked to multiple barriers, especially screening. The screening process like brings a lot of barriers to our studies. How we can improve it? So usually our studies are mainly focused on the study design and randomization. We usually design our study from our perspectives as clinicians, as researchers, and don't incorporate the community perspective. And that's where the problem is, because we are introducing all those barriers. Also, we focus on randomizations and are forgetting about other steps. How about if we just start like thinking our real sampling frame? It's not the people that we have in the clinic, it's not the people that the MGH serve, in general, the whole Massachusetts, but it's really thinking about which of those people we really can bring into our study. And then let's start talking in awareness, let's start talking about engagement, interest, or educating participants, and the return of value. And then when you see it, all of these factors are linked to one specialty or department that we are familiar with. So you can see that sampling frame is usually linked to epidemiology. We can see that awareness, we can just like borrow from the marketing and start like incorporating social media strategies. Same for engagement. We can do increase awareness or educate people by going to borrowing library sciences strategies, and then we have return of value that is more within the ethics, and then things that we are like more familiar, biostats and clinical research. And I'm just gonna skip this because Juliana talk a little bit about this, but basically how to improve diversity in our studies. I think that we need to see these problems as a group and not seeing only them as different steps or like just trying to resolve one at a time. And then if it doesn't work, just going to the next problem, because probably in order to improve diverse representation in our study, we need to like focus on different aspects of our studies, and we need to do several things that sometimes takes time. And I know that for our studies, we usually don't have the time. So as soon as we start doing community engagement, doing community collaborations, working with our health centers, and understanding the community problems, that is as soon as that we will be able to actually improve this representation. And probably it's not going to help you to your actual study, but it's going to help you for future studies. Again, basically use plain language in all your study materials. Try to use a reading level that is between 5 to 8 grade. Just especially because it's hard to read for those that are low income population, for those that English is second language. It is possible. We have designed those flyers and consent forms within these reading levels. And yeah, trying to provide benefits, not only compensation, but also education about research, education about the disease that you are interested in, and do those community partnerships. And that's it.
Thank you so much. Thank you so much, Angie. That was excellent. Thank you for the sweeping, what is the problem and concrete advice. I'd really like to thank all of our panelists who were so passionate that we don't have much time for our panel piece, but we had a nice question asked and answered by Dr. Morrell. Maybe Lisa, when you come on, you can discuss that question, and I have a question too. But I really want to thank you all, and I'd like to thank Women in Science, the Martinos Center, and Radiology, Diversity and Equity and Inclusion, the Office from Radiology, who also helped us get the CME eligibility. So Lisa, I'll turn any other questions to you now, but thank you all. This was simply amazing. Thank you.
Yeah, this is fantastic. And I'm so grateful that we could all kind of learn just from all of the wonderful things we've heard already. I'm very aware of the time, but I do want to see if we can have kind of a brief discussion, even just around one question, because I know you all have really important points of view to share. And I think something that has come up kind of across your talks and across your discussion is the intersection and the kind of inextricability of research and healthcare and health disparities, and then how that all interacts with both social and racial justice, and thinking about how all of those things come together, and what the research community, what the role is that they play in kind of addressing some of these things. So I'm wondering if maybe you could think of a few things to discuss just around what do you think it's going to take from the research community to really activate this pathway of addressing health disparities from the perspective of someone doing research, and how can we really kind of capitalize on that and move that forward? It's a big question, I know, but I know there's strong feelings about it out there.
I'll just say very briefly, join with us in healthcare. Let's figure out new ways. And there was a question asked in the chat about how to form relationships with community health centers. Let's figure out new ways to do that at the hospital level, and then beyond just the hospital, across the region. I think there's a lot of room to move there, and I think it's very fertile ground.
I'll just say that it's something that is difficult and it's going to take time to heal all the abuses, or to all those to build that mistrust, or to build that trust that we need. And for that, we first need to also educate our providers, educate our researchers, because we just don't even know what diversity is. So if we don't understand what diversity is, and if we just don't incorporate different strategies in our research studies, the underrepresentation will continue there. And therefore, we will be not doing a good science, just because we cannot generalize our findings. We cannot be completely sure that a medicine is going to work for all populations, not only for, and usually those medicines are only being tested in white population. So if we don't understand that, and if we don't understand that there are like problems that we need to solve first, such as like building that trust, or such as like providing transportation, because we know that there are like communities that are more vulnerable and that they just don't have the money to go for it. Or if we just don't understand the community and the way that they live, and actually go and show them that we care for the community, so we will never be able to incorporate them or to include them in our studies. It takes time, as I said, and community engagement can take a year or probably more. But it's going to help us for future studies. Best way to do it, benefits for participants and benefits for local providers. And probably you will not be able to give money for to the providers that are located at health centers. But what about if you offer educational seminars? So let's say that you're like talking about depression. Probably those general or those PCPs don't know that much about depression. They just don't know how to identify general symptoms and when is a good time to refer. So let's educate them. And in exchange, they probably will help us to identify participants. So there is a lot ways to do it. And unfortunately, it takes time. We don't have time, but it's a huge compromise.
That's fantastic.
Oh, sorry. I'm just going to also add really quickly that I think it's important for researchers to be open, honest, and transparent about systemic oppression, and also the systematic exclusion of certain populations from research. And it's important then to build relationships that are sustainable and lasting with the community as well, as Angie was saying.
That's great. Yeah, I know that we're at time, and I think we could probably devote an entire another hour to some of these conversations. I would love to do that. So if you guys are free another time, we might call you back up. But I want to thank you all again for coming, both to our attendees, but also especially to our panelists for providing such a wealth of insights and a wealth of knowledge in this topic. It's something that I think we can't learn enough about. So I very much look forward to continuing to have these conversations. And if there are any questions out there that haven't been answered, please feel free to get in touch with Women in Science, and we can kind of connect the dots for everybody and get everything answered. We have a lot of people who are willing to talk about this, which is important. So I wish everybody a good afternoon, a good weekend, and I'm sure we'll have this discussion again soon.
Thank you all.
Thank you so much.
Thanks, everyone.